Start your Bismillah ar-Rahman ar-Rahim. Welcome in this new meeting of Egyptian Society of Nephrology and Transplantation, CME chapter online meetings. I am pleasure today we have to have two of great stars and great professors of Egyptian Society of Nephrology and Transplantation and African and even international nephrology community in this session. Which is concerned with genetic nephrology and transplantation. I am really pleasure to have Professor Ahmed Elkeraie as a speaker and Professor Gamal Saadi as the moderator of this session. Let me introduce Professor Gamal before I leave him the floor to lead this session. Professor Gamal Saadi is the Emeritus Professor of Nephrology and Medicine in Cairo University. He is the past president of Egyptian Society of Nephrology and Transplantation and the current president of African Society of Organ Transplantation. And Professor Gamal is well known for his international publications in the field of kidney transplantation and in nephrology in general, and mainly interested in kidney transplantation. And nowadays he is interested in genetic aspects of kidney diseases and aspects of kidney transplantation. Welcome, Professor Ahmed Elkeraie, our speaker today, who is the professor of medicine and nephrology in Alexandria University and the head of nephrology unit in Alexandria University. He is ESNT board member and is currently the chair of genetic working group, genetic kidney disease working group in African Association of Nephrology. Our topic today is concerned with genetic preparation of kidney transplantation, genetic basis of pre-transplant kidney preparation, and we'll listen to the lecture by Professor Ahmed and then come to the discussion after the end of the session. I'm expecting a very hot a very interesting lecture and a very hot discussion following. And I would like to welcome all of the attendees and all of the professors who are joining us successively and are present with us now and will share us in the discussion following the lecture. Before I leave the floor, I would like to thank especially Dr. Mu'tasim Sayed, who is the lecturer of medicine and nephrology in Mansoura Nephrology and Urology Center, and one of the very active members of CME chapter of ESNT, Egyptian Society of Nephrology and Transplantation. And we would like to thank him for his work regarding this session and all of his work regarding CME chapter. So please, Professor Gamal, start this session and take the floor to lead the session and further introduce Professor Ahmed.
Thank you very much, Professor Yasser, for this very kind introduction, and for your very enthusiastic and very keen activities in maintaining this webinar and teaching courses we are all learning from. The topic of today is very interesting and very difficult and very hard topic, because it's addressing one of the important and crucial aspects in our transplantation practice. Because genetic testing is not a routine investigation performed in our preparation. It requires very meticulous selection of cases to whom we should direct our attention to mandate performing genetic analysis prior to proceeding with the transplantation practice. I believe this is very important and very crucial, because in some categories it might direct to the type of treatment, whether to proceed with kidney transplantation alone or require combined liver and kidney, or in special situations it might direct us for some cases or even relatives of the cases to perform preemptive liver transplantation alone when we have a reasonably normal kidney function. In other situations, it might direct to therapeutic modalities or therapeutic challenges, and without selecting these therapeutic modalities, you might get failure of the transplantation. We might also be facing situations for recurrence of the original disease, which requires special situations and medications. This is completely different from the genetic analysis to detect the state of tolerance, to detect the state of rejection, which is, to me, is a bit luxurious pathway. But the initial preparation seems to be mandatory in some cases. Its availability is not that easy for every center or in every country. And getting the data and analyzing the data is equally very difficult. I'm sure Professor Ahmed Elkeraie, whom we all learn from, and he is very intellectual and very enthusiastic in that field. And he will give us now the talk to see how we can approach the aspects I am discussing, and probably will hear from him a bit more. Professor Yasser has already introduced Dr. Ahmed, and we are all keen to listen to his presentation. The floor is yours, Professor Ahmed.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thanks, Professor Jamal. Thanks, Professor Yasser, for the kind introduction. And thanks, special thanks for Professor Jamal for the very nice resume for the case and paving the floor to the presentation. Actually, these 2 minutes that you have addressed are really the core of what we should do in our pre-transplant genetic workup, and you elegantly mentioned most of the points that needs to be fostered in the brain of each nephrologist who is working in the field of transplantation. So let's start, and I really would like to have plenty of discussions, as Professor Yasser mentioned earlier. So let's start and look what should we do and how we should rationalize and use the genetic testing in the proper way in the field of preparation for kidney transplantation. I thought that the best way to do that is starting with some cases, just to let you know that these are real life scenarios that we met, and that the practice of genetic testing and genetic counseling would be mandatory before going for transplantation in such scenarios. So this is the first case. It's a 45-year-old male. He has a past medical history of hypertension and a family history of end-stage renal disease. And this should be very much highlighted. These are one of the essentials of what you need to take in the history, and it might be a big clue to the need for genetic testing as a preemptive before going into full evaluation for kidney transplantation once you have a family history of end-stage renal disease. The clinical presentation was a bit bizarre. He had a baseline of a creat over 2 between 2019 and 2021. Renal function tests started to deteriorate rapidly, and creat over 3 months reaches from 3 to 8, and he became hemodialysis dependent. His labs has a normal anemia, platelets were normal, LDH was upper limit of normal, urinary albumin creatinine ratio is a 0.9 gram per day, and ANA, anti-DNA were negative, C3 and C4 were normal. In the view of the AKI on top of the CKD, he was biopsied. And the biopsy showed chronic thrombotic microangiopathy with focal dominant C3 deposit. So the biopsy showed a TMA, which goes with his hypertension that was recently uncontrolled, and there was some dominant focal C3 deposit. And if you read through the biopsy, there is significant global glomerulosclerosis, mild to moderate interstitial, only mild interstitial fibrosis. And if you read through 12 glomeruli inferior section out of which 4 were globally sclerotic, but there was a picture of chronic TMA in the biopsy with focal segmental mesangial anglomerular basement membrane deposits of C3. So we're faced with a case of chronic TMA with some C3 deposit. This can be secondary to the uncontrolled blood pressure, or can be a primary renal disease with the uncontrolled blood pressure as a consequence of this. And because the patient was a middle-aged man, he was seeking transplant, and he came asking to proceed for kidney transplantation. In the view of this biopsy and of his family history of end-stage renal disease, we thought that it's better to have a genetic testing aforehead. And this was the genetic testing. We thought for whole exome sequencing, and the whole exome sequencing showed that mutation, and this mutation is a heterozygous mutation, and in the gene for complement factor H, and it's inheritable in both autosomal dominant and autosomal recessive. At the time of this test, back in 2022, it was uncertain significance. That was the classification of this specific mutation as a VUS, or a variant of uncertain significance. But it is related, though it is an uncertain VUS, or a variant of uncertain significance, but it is related, the mutation in complement factor H is related to atypical hemolytic uremic syndrome susceptibility. So we thought that we can go for later on a Sanger, and the Sanger for the same gene, which was gene mutation, which was detected here in the region of complement factor H, was as well associated with positive heterozygosity, the same, but at that time, just almost 6 months later to the previous test, this was changed from a variant of uncertain significance to a likely pathogenic variant. So now this is the detection of a likely pathogenic variant in complement factor H, which is associated with complement factor deficiency and consistent with your patient's symptoms or phenotype, assuming autosomal dominant inheritance. So in this way, you have a patient with atypical hemolytic uremic syndrome who has a genetic cause for this atypical hemolytic uremic syndrome that would be highly recurrent in the transplanted kidney, and we denied the patient to be transplanted. This is a second case with a female of 32 years old, no past medical history, accidentally discovered renal impairment with low-level proteinuria, hypertension, and edema. Her basic immunology was negative, C3 was slightly consumed, and C4 was normal, so she was biopsied as well, and the renal biopsy showed a picture of C3 glomerulonephritis. And this is her biopsy, showing focal segmental and global sclerosis in 60%. It's a bad kidney, unfortunately, with a mild interstitial fibrosis and tubular atrophy, but she had a picture of C3 glomerulonephritis according to her immuno and light microscopy. Over 3 years, she progressed to renal failure with no response for immunosuppression, and creatinine reached 9, and she started hemodialysis, and she's looking for kidney transplantation. Again, C3 glomerulonephritis should be checked for by genetic testing to see the possibility of recurrence as a part of the initial workup. So we did a whole exome sequencing, and the whole sequencing he cited of a negative, no clinical that can account for the patient phenotype. And this means that the case of C3 glomerulopathy in such a patient is related to the antibodies and not to the genetic variant or the mutations. And this means that this patient can be transplanted, and she's already working her preparation for kidney transplant right now. So negative result in genetic testing allows the patient to proceed for transplantation. The third case, this is a 22 years old male, steroid-resistant nephrotic syndrome since childhood. He received different immunosuppression with no clinical or respiratory response. He received steroids, MMF, CNI, and even rituximab over those years. And further workup, his immune markers were all negative, and the biopsy showed membranoproliferative GN with all range of possibilities. This is the case of chronic GN and now became an end stage, and he is still young and willing for transplant. His mother was very keen to transplant her son. Unfortunately, again, when we thought for the biopsy, for the genetic testing, he was shown to have a complement factor H related protein 2 with a pathogenic autosomal dominant variant that fit into the patient phenotype, which is C3 glomerulopathy and immune complex mediated MPGN. So unfortunately, this patient had a very high possibility of recurrence, and he should not be transplanted at his situation. This is the last case before we go to the mainstream of the lecture. This is a 33-year-old female with a 4-gram proteinuria, creat of 2.3 milligram per deciliter. She had hematuria, microscopic, positive in ANA, but negative anti-DNA, and seasonally low. Again, her light microscopy showed, as you can see, a C3 deposition in the GPM and mesangium with negative immunoglobulin. So it's considered again as a case of
الصوت بيقطع. The voice is not constant يا دكتور أحمد. Could you repeat the diagnosis you mentioned?
had test and the test very peculiar.
We can't hear you يا دكتور أحمد.
Okay, should we resume?
Yes, please.
Okay, so we were just saying this is another case. We had now 3 cases. One is a typical HUS with positive genetic testing. The second was a C3 glomerulopathy with negative genetic testing. And the third was an MPGN pattern with positive genetic testing. 2 of them were declined to proceed for transplantation based on the positive genetic testing and the high incidence of recurrence. And the third was allowed to proceed. This is the 4th case, and that case is a 33-year-old female with a proteinuria of 4 grams and a renal impairment with a creatinine of 2.3 milligram per deciliter. She had microscopic hematuria, positive NA, but negative anti-DNA, and marginally low C3 and her biopsy again showed the patient EGN with even 40% crescents consistent with C3 dominant glomerulonephritis. So the patient again was instructed to have a genetic testing, and she had a genetic testing. The genetic testing shows copy number variant. It's not a mutation in this time. It's not a just or nucleotide. No. طيب يبقى okay. So you're just saying that these crescentic consistent with C3 dominant glomerulonephritis. And we thought the genetic testing and the genetic testing showed a copy number variant, which is something different a little bit from the mutation or the SNP. And this copy number variant was encompassing both complement factor H-related protein 1 and complement factor H-related protein 3. And this is proven to be associated with atypical hemolytic uremic syndrome. And as you can see here, there is a one copy loss encompassing the entire gene in CFHR1 and another one in CFHR3, and this is the pathogenic, and its phenotype is related to the hemolytic uremic syndrome atypical form. But if you look for the analysis of these variant interpretation, you would find some very interesting things. You find that this CFHR3, CFHR1 can be differentially manifested in different population between the Asians and the Caucasians and the Japanese and the as well, where it can be associated with a disease pattern like atypical hemolytic uremic syndrome in some of these ethnicity. It can be associated with no disease pattern in some other ethnicities. For example, in Nigeria, it is reported to be in normal population up to 33%. In other variation from 12%, whereas it is very rarely reported in the Caucasian population from 1 to 5%. In some situation, it is associated with more resistant form of IgA nephropathy, or in other, it is protective against IgA nephropathy, but increases the risk to lupus nephritis and progression of lupus nephritis. And here in specific situation, it can be just a predisposing factor to the occurrence of autoantibody mediated atypical hemolytic uremic syndrome, not directly related to genetic type of atypical hemolytic uremic syndrome. And thus, these do not preclude transplantation, neither it does not preclude the treatment by complement inhibitor, for example, the eculizumab or the ravulizumab, as well as other forms of immunosuppression. So this is another issue. Although it's a genetically mediated in a way or another, but it needs a specific second hit that interacts with an autoantibody. So we should look for autoantibodies in this specific patient. For example, antibodies for factor B or sure whatever. So these were some cases that the different drugs would do beforehand of going for transplantation, and that would definitely affect the prognosis of the patient and whether even he would be transplanted or not. Now, this is the core curriculum of nephrology that have been released a few months back by the AJKD in clinical genetic testing in nephrology. And if we look here for the specific recommendation for genetic testing, you can see that a strong family history is the very first cause for recommendation for genetic testing. A multi-organ syndrome of unknown etiology, a typical clinical presentation, when results may guide therapeutics, in particular when you are not going to use immunosuppression because there wouldn't be any response, or when it is requested by the patient himself to be sure for his family, when a kidney biopsy suggestive of a genetic cause like a chronic TIN, like FSGS, with no secondary cause, like abnormalities of GM suggesting collagenopathies like in TMA, or idiopathic MPGN, lipidoses like in Fabry's and others. And when there is a CKD or end stage of unknown etiology after comprehensive evaluation, again, when there is unexplained electrolyte abnormalities, or when there are some ciliopathies or cystic kidney disease that cannot be explained with a positive family history, and testing when there is a donor evaluation, as you can see. Then how you would proceed if the patient or suspected to have a same disease as in affected relative, you would go for testing for a specific virus would be ideal. Example, PD1. So it's simple in that if it's unknown, you would go for large multi-disease kidney panels, targeted NGS or targeted panel. You'd ask for a panel that goes with the type of the phenotype that the patient is presented with. For example, if the patient has some form of electrolyte disturbance, you would go for a tubulopathy panel like the Claudin 16, Claudin 9, and Bittelman and others, all these other type of genetically mediated tubulopathies. If the patient is presenting by cyst, you would go for the cystopathies or the ciliopathy panel, steroid resistant nephrotic syndrome. Sometimes the patient might present by a very vague picture, like, for example, a CKD of undetermined etiology with no clue. So you would go for a larger or broader type of gene, the whole genome sequencing. Even more, if the patient has a takeout or the congenital anomaly of the kidney and urinary tract, or with other types of what looks like to have a chromosomal anomaly, you would go for the chromosome directly. Then, for how this can affect kidney donation, if you go through the implication of kidney donation, starts by doing the donor assessment, especially if the recipient of unknown, it need to look, the donor do not have specific disorders like polycystic kidney disease, Alport syndrome, or whatever. You might need to donor as well, but also sometimes even genetic, for instance, in Apple 1, you might need to assess the high-risk group for the African American before donation, whether they have and we maybe some of us have came by Professor Ifyoma and Adwia in the role of Apple One in the African population. And if you find that your patient, one, for example, you would never take a kidney from him, or at least you have to explain the added risk for such a patient. Now, if we move to look for the genetic testing in related benefits, what are the points of controversy and what are the related risks? And this is for the couple, both for the donor and the recipient. Definitely the benefit would be patient and characterization, clinical diagnosis, provide the diagnosis for CKDU and inform the family planning for the whole family, not for only one patient. And again, you can look and inform, which is the most important in relation to kidney transplant, the possibility of recurrence of the primary kidney disease in the allograft. Again, if you look for the potential risk of inherited kidney disease or progression for the donor after nephrectomy, to enhance the safety of kidney donation based on a comprehensive making medicine. The point of related to genetic testing prior to transplantation. First, optimal approach of genetic testing in the recipient and donor candidate might not be. You cannot put an algorithm right now for every single patient, but there are situations that definitely mandate you to do the genetic testing, and others definitely it's not like an HLA or an ABO blood grouping that you would do for every standardized diagnostic criteria for CKDU. It's not yet available. Preferred genetic, what are you going to do? As we this in the last slide, a single gene, and you might miss many others, or targeted panel based on the patient phenotype, or a whole exome sequencing, or even more, a whole genome sequencing. Definitely, when you go few times, you can use the tool. You would master using the proper test. Likewise, like when you ask for ANA for screening, and then you ask for the anti-DNA for specific diagnosis. You would do the same with genetic testing after a while. And then interpretation of genetic variants in healthy donor. Sometimes look phenotype, and then you can find an abnormal genotype. What are you going to do? How are you going to interpret the result? And that's why pre-test genetic post-counseling is very, and it has rules and bases that you have to do along with the family of patient and the potential of the family members as well. Definitely, there are risks like the decision. It's not a pathogenic. It's not a benign. You cannot define yet. This might motivate you to testing, and this might be not cost effective. Definitely, there is a psychological stress to the donor and the family as well, and it might reduce the opportunity of living donation. But after all, this definitely might be a good tool for optimization, even if it costs, but savings are huge. I mean, even if you paid like $1,000 more in the preparation, but you've got a patient that would have lost his graft if he transplanted, that not only, especially when our grafts related donation, only a matter of money, it's an organ in scarcity of the organs cases, and these broad lines we've just introduced to the, and here you can see that move the unknown or to a hereditary type, and this cohort of 85, 20 already were known as hereditary. Most of them were Alport and autosomal dominant. 56 were thought to be non-hereditary. Of these 56, 6 patients turned to be having a genetic background. So this definitely would improve your management for your potential transplant patient. And this is the outline for the now what we're going to go through, hopefully in more like 20 minutes. First, the introduction, and these are most of the recurrent genetic diseases that needs to be reassessed previously, and livings classified by groups like steroid-resistant nephrotic syndrome, like cystic ciliopathies, atypical hemolytic uremic syndrome, nephrolithiasis and nephrocalcinosis, and others. But are all genetic diseases recurrent post-transplant? Definitely the answer is not. We don't have a recurrent polycystic kidney disease, which is the most widely distributed genetic disease in the kidney. And are all recurrent diseases post-transplant are genetic? Again, definitely no. We have nephropathy for members. We have recurrence for primary FSGS, which is even much more than the familial or genetic type of FSGS in the incidence of recurrence. So renal diseases post-transplant can be genetic recurrent, like C3 glomerulopathy, atypical HUS, FSGS, the familial usually is not that much, steroid-resistant nephrotic syndrome, depending on the mutation, primary hyperoxaluria. Alport is not actually a recurrence, but a predisposition to another disease, which is the anti-GPM. On the other hand, there are genetic non-recurrent diseases, so you can transplant these without genetic testing based on their phenotype, if you know them, like autosomal dominant polycystic kidney disease, autosomal dominant polycystic kidney disease genetics before transplanting him, autosomal dominant tubulointerstitial kidney disease, and these are 5 types: mucin 1, and the previously known familial juvenile hyperuricemic syndrome, the HNF1B1, and the uromodulin, the most common form of them. And these again are not recurrent. Fabry's disease is not recurrent as well. Thin basement membrane disease, that was previously thought to be 100% innocent is now recognized to be one of the collagenopathies that is not 100% innocent. There are few cases that can progress to end-stage renal disease, and this is not a recurrent disease in the transplanted kidney. And these are some of the non-genetic diseases that might recur in the transplanted kidney, as we've mentioned: IgA, focal primary form, membranous nephropathy, fibrillary amyloidosis, and others. If we go for the genetic disease that have an involvement with known genes, ADPKD on top, and this is not recurrent, as you can see, FSGS, the genetic form, less likely than the non-genetic form to recur, and the recurrence is described in nephrin and bodocin mutation rather than other types of mutation. Liver-related donation, according to the type of mutation, specific type of mutation like the arginine B22 might be a contraindication for liver donation. Alport syndrome, it does not recur, but it can develop anti-GPM, as we know, because those patients do not have the exposure to the collagen before the alpha subtype of the collagen A3 or A4 or A5, according when they are transplanted with a normal kidney. This is the first exposure to this collagen subtype, and this might cause anti-GPM. Thin basement membrane disease, it does not recur. Autosomal dominant tubular interstitial kidney disease occurs, and it would need anti-complement therapy, maybe for life, according to the situation. Sometimes there are some extrarenal manifestations that mandate you to look further in depth into the genetic pattern. Like, for example, in type 4 collagen, the Alport, you would look for the sensory neural hearing loss, or for the appearance in the. And although this might not be in, but it would be very. The NPHS1 is associated with an early onset steroid-resistant nephrotic syndrome. The Dennis-Trash syndrome with a Wilms tumor and male pseudohermaphroditism. This can occur with the Wilms tumor type 1. Again and again, you would have, for example, here, this Schemke immune osseous dysplasia, which, by the way, can be transplanted. It's not known to recur, but you have these immunological defect. You have these osseous defect and these renal failure as well. Syndromatic appearance. On the other hand, you can get it the other way around. If you have, for example, these Charcot-Marie-Tooth disease with motor and sensory nerve manifestation and delayed steroid-resistant nephrotic hand of going to transplant the patient. Anal patella syndrome with hypoplastic patella, dystrophic nails, and this collagenofibrotic glomerulopathy, you should go for testing as well. Again, these are some of the genes that are implicated in glomerular pathology with systemic diseases, like in diabetes, both type 1 and type 2, with the lipoprotein glomerulopathy, with the Fabry's disease, with the LCAT, the lecithin cholesterol acyl transferase, where you have the fish eye disease, and with some of the glycogen storage disease. These primary CoQ10 and CoQ6 and CoQ diseases, because they are potentially preventable chronic kidney disease by just supplementing the patient with coenzyme 10, and this can help to prevent the disease progression in many of these patients. So after all the diseases and their recurrence in kidney transplant can be classified by the cause, whether it's immune complex or glomerulopodocytopathy or deposits, organized deposits, or a paraproteinemia or whatever. It can be classified by the prevalence, whether how much it is prevalent, the IgA nephropathy, the FSGS, the membranous, and the MPGN may vary from different regions to this. From 15 up to 40 and maybe 60% in some type of these diseases, and may vary again by type. Usually as after with IgA nephropathy or dense deposit disease or amyloidosis, and very late recurrence, like after 5 years, usually occur with recurrent fibrillary GN or collapsing glomerulopathy or proliferative GN with MID. Now, let's move to some of the specific situations, like, for example, steroid-resistant nephrotic syndrome. This is a long list of genes that are involved in specific types of these resistant nephrotic syndrome, and these are the prevalent histology, what FSGS and FSGS causes, and these are some of the genes implicated, and these are the particular proteins that they regulate for or the function. And if you look here for the critical reanalysis of the post-transplant recurrence in genetic nephrotic syndrome, you would find it is very rare, a bit puzzling. Although the steroid-resistant nephrotic syndrome might be mediated by some genetic mutation, but the mere familial FSGS is very rare to recur, even much rarer than the primary FSGS, as we mentioned earlier. And the clinical presentation with proteinuria, often in nephrotic range, in the early post-transplant period, usually in 6 weeks, with extensive effacement of the food processes by the EM, usually more than 80%. And there are some, and these points can be very important before analysis for transplantation. The high risk, if it is lost from a recurrence early on, a childhood is at a high risk. The rapid progression to uremia after FSGS, the mesangial proliferation is a high risk for recurrence. A living donation is high risk than a cadaveric, and elderly donor and the white race are higher risk for recurrence. On the other hand, the familial or genetic subtype, the sporadic Bodosine mutation, and the slow progression and the non-nephrotic range of proteinuria are a lower risk for recurrence. So you can phenotype your patient before even transplantation for an FSGS patient. And these are the main differences between recurrent FSGS versus de novo FSGS. And it is important because the recurrent FSGS can be treated early on by plasmapheresis, CNI, cyclophosphamide, and rituximab if was picked up very early in the course of recurrence in the transplanted kidney. Whereas the de novo, you look for the secondary etiology treat. And this is the approach again for the management of early FSGS recurrence, pre-transplant, and this is the main point. Pre-transplantation, you measure the proteinuria if the patient is not anuric, and then post-transplant, you have to measure the protein weekly for 4 weeks, and then monthly for 6 months, and then whenever proteinuria or hypoalbuminemia or edema develop in those patients, to start early treatment by plasmapheresis, cyclophosphamide, or rituximab. For C3 glomerulopathy, we've already mentioned a few cases of C3 glomerulopathy, but we're going to look for the algorithms for how and what to do with such a patient. First of all, we now know that MPGN is now classified based on immunofluorescence. Either if it has an immunoglobulins and complement, you look whether this is a monoclonal, you go for paraproteinemia assessment. If it is polyclonal, and immune mediated, look for lupus, Jugra, and others. If there is no immunoglobulin and it is a C3 dominance, it's either T3 glomerulonephritis or a dense deposit disease. And you would proceed by testing for complement dysregulation by autoantibodies for complement factors or genetic testing for complement mutation. If there is no complement, no IG, and it is an MPGN pattern, especially with mesangiolisis and doubling contour and everything that you know, this is probably a TMA, and they are all related. This is a picture of the DDD, as you can see, and these are the picture of C3 glomerulopathy with different deposition. And these are the different patterns of complement-mediated diseases, including the post-infectious, or better called now the infectious-related GN, the dense deposit disease, the paraprotein-associated glomerulopathy, the C3 GN mediated is a DDD, and the 2/3 of cases is C3 glomerulonephritis. And there is an overlap between the C3GN and the immune complex mediated MPGN, and this particular area might be a little bit difficult to diagnose. That's why you need to do a patient for transformation between the types. Sometimes we do a pronase treating for the tissue was not apparent by the immunohistochemistry in the early staining. And these are the complement-mediated kidney disease, again, with the atypical hemolytic uremic syndrome and the C3 glomerulopathy, and the, again, interaction between them. If you remember the early cases, one as C3 and the third with DDD, and the pattern is really intersecting even in the pathology and definitely in the clinical picture. And this is the MPGN pattern of glomerular injury. Again, the immune complex, the complement, and the non-immune complex mediated. And you can see here with the complement C3GN, the mutation can be in the complement regulating protein, or it could be an antibody. And again, just to remind you, if it is an antibody, you can proceed for transplantation, and the immunosuppression for your patient can deal with these antibodies. Usually, you might not need even the eculizumab or the ravulizumab, but if it is a mutation in the complement regulating protein, so you would have always a problem, and you need to suppress the products of the complement continuously, maybe for life. Although a recent report say that you can stop after some years, and this usually should be diagnosed beforehand before going to transplant. Maybe a third option, as Professor Gamal always mentioned, is to transplant the liver again, likewise as we do in the primary hyperoxaluria, type 1. And these are some of the inherited abnormalities we've just mentioned. These can be complement-related mutation, or it can be an factor H related protein 3 and 1 major deletion of both genes. These are the genes that are important in regulation of the complement factor H, which is the factor that usually moderate the regulation of the alternative pathway of the complement. And this is the familiar MPGN, and as you can see, maybe this paper, the B7, see that there is always a concern over the use of living donor in familiar renal disease or of developing significant renal disease, and this was related to the complement factor, as you can see. Okay, and if we to the atypical HUS, again, these are the main point to differentiate the recurrent from de novo atypical HUS. Usually, typical 6 in transplanted kidney, antiphospholipid antibody syndrome, associated complement dysregulation are all recurrent forms. The most important is the associated complement dysregulation. Morphology is not diagnostic. You cannot say this is an autoimmune disease mediated atypical HUS. You cannot say this is the genetic type of atypical HUS. The morphology is the same in most of the cases. On the other hand, the de novo HUS, it's more common. It might be related, as you know, CN even cause an HUS. Antibody-mediated rejection can manifest by a TMA, as you all know, and transformation from native kidney C3GN. So a native kidney in a transplanted patient can proceed with a C3GN, can proceed to have an HUS as the recurrent TMA. It could be a patient that was not diagnosed with a TMA prior to transplant, and it recurs in the transplanted kidney, and it was thought that it is a de novo. And this paradigm is very important for the post-transplant HUS. The recurrent HUS is more related to the genetic susceptibility, whereas the HUS is less related to the genetic susceptibility. There is a donor. This is membrane cofactor is a good factor here. It's relatively the least to cause recurrence, and it might have some beneficial effect in comparison to other types of mutation, like in factor H mutations. It could be an autoantibody, or it could be a mutation. These can be prevented usually by treatment, and these are highly recurrent, and you can do nothing except if you're going to give a continuous lifelong complement inhibitors. And these are some of the complement factors that mediates the recurrence, and here are the recurrence. As you can see, complement factor H up to 90% recurrence, complement factor I up to 80% recurrence, complement factor B 100% recurrence, C3 mutation 40 to 70% recurrence. The least would be MCP or membrane cofactor protein. The THPD, it's one case with a recurrence, actually 100% in this case. The same in this table, almost the same results as well shown. And again, these are the complement abnormalities, different types, whether mutation or autoantibody. Look here that the graft failure can occur with most of these mutations. Here, but the MCP is the least to have the percentage of recurrence and graft failure. With the autoantibody, only one in 5 had a recurrence, whereas with others, almost all for the MCP had recurrence. For the mutation with the C3, very high recurrence. For factor B, very high recurrence. For THPV, again, very high recurrence. In those patients, you don't go for a family-related donor in most of the situation. Okay, and these are the workup that you do in a patient with typical HUS. The classical workup is you do the basic level of the complement, C3, C4, factor B, and C5, and the regulators like factor H, factor I, CD46, and properdin, and the function even CH50 and factor H function, and the autoantibodies, and then you would go for the genetic analysis for factor H, factor I, and C3 and factor B, and the rearrangement in factor H related proteins as we mentioned earlier. And again, according to what you have found out of these panel of testing for those patients with atypical HUS or C3 glomerulopathy, would do your risk assessment for your pre-transplant patient. If you have a previous recurrence or you have a complement gene mutation in CFH or CFB or C3, you should give a prophylactic oclizumab before the transplantation. If you have a no pathogenic complement gene mutation and isolated factor I or persistently low anti-factor H titr autoantibody, you can consider if it is and negative antibody, you give no prophylaxis. Those patients are less likely to have a recurrence in their transplanted kidney. Now we move to primary hyperoxaluria. This is a straightforward. You have three types of H1 with the AGXT and PH2 with the GR-HBR. The end result is the kidney damage by the nephrocalcinosis and the oxalate deposition. And please remember, it's not only the kidney. Oxalosis and oxalate deposits is not only in the kidney, it deposits in many, many organs in the body, in vital organs, and it can lead to death. Again, these are the main three types, and these are the chromosomal location for the genetic abnormality. The onset for type 1 can be in any age, but usually it occurs in childhood, whereas type 2 and type 3 can occur in any age as well. All of them presents with the calcium oxalate crystals and renal stones, but nephrocalcinosis and renal failure is the salient feature of type 1. Type 1 can be given hydration and pyridoxine here is even a specific point because abnormality or mutation, but it is not a single mutation. There are different types of mutation. One of these mutations can have response to pyridoxine, others do not. So even within the mutation in the gene, the type of mutation itself can tell you whether the treatment or the severity of the disease, what it is. So it is very important to test for the specific mutation. Definitely here, the standard of care is to transplant the liver and the kidney, or you would go for the short interference RNA for life after transplantation. And here, you transplant the kidney if the patient reached end-stage renal disease. Here, usually, it does not go to end-stage renal disease, and transplant wouldn't be required in type 3. This is out of our scope tonight, but just to let you know that now many lines of treatment, the pyridoxine citrate and neutral phosphate, the allograft transplantation is the classical, but you can target the inflammasomes by different NLRBs and others. You can work on enzyme with 9 techniques and gene editing, or you can give a chaperone therapy by the betaine or by the pyridoxine again, and you can reduce the intestinal oxalate by the oxapathat or the oxazyme. And maybe is the man has mentioned earlier that you can give as well to do a substrate reduction therapy, and these two are among the FDA approved short interference RNA or silencing RNA in the management of primary hyperoxaluria. There is a long-term outcome for the transplant. The endpoint is you have to reduce the oxalate to below 20 micromole per liter before going to transition immediately of the graft, be accompanied silent or by dosing with online HDF till you go with the plasma oxalate to below 20 micromole per liter, and then you can transplant the liver or simultaneously with the kidney, or the liver beforehand and then the kidney later on. As far as Alport, we've mentioned earlier, Alport is not an issue in transplantation, although you can have recurrence, and if you had a recurrence in the first graft, you would always going to lose the graft in 3/4 of cases, and it would recur even worse in the second graft. Now, let's end by donor perspective. What should we do with the donor from a genetic background or genetic point of view? There are autosomal recessive diseases that progresses to end-stage renal disease. This is important. Why? Because those patients might not be diagnosed, and you might miss their phenotype in the routine testing. And hence, you would need to test for them specifically in mutation with the arginine 229 that we've mentioned, that this type, a living donor transplant nephrotic syndrome, except if the patient, have this type of mutation in the donor has this type of mutation, so you have to for them for the nephronophysis, there is no problem of having a living related donation for a typical HUS, as we mentioned earlier, you cannot have a living donation. In type 1 PKD and type 2 PKD, autosomal dominant mediated, yes, you can, if you prove that the relative is unaffected, and there is a way to prove that. We'll come to this. In atypical HUS, whether autosomal recessive or autosomal dominant, you're not allowed to take a donor from the family. In Alport syndrome, you have to clarify in X-linked type of Alport syndrome that a female who is a carrier more than 45 years old and without proteinuria, you can take her, but you have to explain that she's for progression. If she how to take her. The donation from a donor that you prove is not carrying the disease. And this is the same when to take from a polycystic kidney disease from a female X-linked with Alport, atypical HUS are not allowed. And this is the approach for how to test for living donation. You evaluate the recipient if he is a related living donor, if the recipient has any of these factors, so either by targeted panel or by OS. And according to what you feel, if a positive result for the recipient, you should test the donor. If a VOS for the recipient, you should test the donor. If it is negative result for the recipient for genetic testing, you don't need to test the donor. When you test the donor, if it's positive, you definitely will exclude him from donation. If it is variant of uncertain significance, you have to discuss with him that this might preclude him from donation. But if he insists, he should be clarified that there is a potential added risk. If it is negative result for the donor, go ahead and continue with donor evaluation. So these should precede the routine donor evaluation. If it is an unrelated living donation, biologically unrelated, for example, a spouse donating his wife, and there is in the donor family, again, with one of these, you have to test the donor by targeted gene panel or by OS, and according, again, you would go likewise in the previous. How about the autosomal dominant polycystic disease? The patient is more than 40 years and he has less than one cyst in his kidneys or only one cyst in his kidney. You directly go for donation by ultrasound only. If it's between 30 and 39 and he has no cysts by ultrasound, again look by an MR. If it's still no cysts by MR, go for kidney donation directly. If the patient is less than 30 years, negative ultrasound, negative MR, still you need to do genetic testing, mainly for PKD1 and PKD2, which comprise more than 90% of the cases of genetic mutations. If all these are negative, donation. Now, I think that journey with the pre-transplant genetic assessment for the donor and the recipient, of course, focusing in the recipient of the potential recurrent diseases to identify and potentially prevent or abstain from the transplant operation if they're highly recurrent and non-curable, and for the donor to prove that the patient is safe and sound to donate, inshallah. I'm happy to have any questions and comments, and thanks for your patience with me.
Thank you very much, Professor Ahmed, for this very elegant presentation. It was very comprehensive, and you covered a very difficult and hard task for any nephrologist to consider the patient who is following up for transplantation, either to proceed or to deny the transplantation if we have the background of genetic analysis available. I think in the cases you presented, the first and third case, you considered not to proceed with transplantation. What is the background of refusing the progress with transplantation?
Those patients had a proven genetic mutation for complement factors, and it's not actually a scientific decision, it's a practical decision. We can proceed for transplantation if we're going to use a complement inhibitor in a way or another, or definitely if we're going to use a combined liver and kidney transplant. But if a simple kidney transplant for a patient with atypical HUS who is proven to have factor H-related protein, the incidence of recurrence is more than 70%, if not treated by a complement inhibitor. And the same for dense deposit disease, this goes for up to 90%.
So the exclusion from transplantation is dependent upon the availability of the complement inhibitors, the financial aspects, and the availability of liver transplantation as well. But these are solutions which can be considered in our community to supply combined liver and kidney in such cases, which would be even cheaper than if you have the anti-complement treatment. But if you can cover the peri-operative period by anti-complement, you might tide the initial period with the anti-complement and proceed only for 3 or 6 months with the anti-complement, and then wean it off and monitor for any recurrence later on. So this is a very difficult task to proceed with, but it is very hard to deny a patient from transplantation simply for the availability of the treatment or not.
This is absolutely right, but there is another major issue in this situation, which is, as shown in the literature, in cases of atypical HUS, you're not allowed to take from a relative as well. So you need to have.
This is a different issue. This is a different issue. But we can.
Yeah, I mean, the best solution for such a patient would be a cadaveric donation with a complement inhibitor. This would be the best for such a patient.
Let me ask you another question. You mentioned here that if it is a typical HUS and we are going to proceed with transplantation, and we are having the anti-complement treatment, or we will have combined liver and kidney, would you consider paired kidney donation in such situations? In another way, would the living donor of that patient be suitable for another case?
This would be an excellent solution. Of course, after testing the donor for the complement mutation, to be sure that there is no mutation in the donor. It's a must to test the donor, even if he is not manifested.
That is exact, but you are touching a very important issue, is that the mutation which is not manifesting might not still allow him to donate. Probably some mutations can allow a donor to or a patient or an individual to donate, and sometimes it might not allow him to donate. So this is a very difficult task to consider the importance of the genetic test and the genetic analysis, and revising the literature for such cases to allow him to proceed with paired donation or not. So this is a very difficult task and a very difficult situation to consider, and highlights the importance of proceeding with the genetic test in such difficult situations. My last question for you is that in one of your genetic analysis, you considered the proceeding after whole exome sequencing the West. You revert again to the Sanger.
Sanger,
I don't believe this is might be very essential. Once you diagnose by the WES or the whole exome sequencing, it's not mandatory to proceed with the Sanger because it's a limiting factor. Rather, the whole exome sequencing is a broader analysis and gives you the prospect of getting even de novo mutations which are not yet analyzed. And I would mention here that in your work, you detected de novo mutations which are not present in the literature by the whole exome sequencing. If we revert to the Sanger, you will not detect it.
This is an important issue, actually. The whole exome sequencing is more sensitive to detect the mutation. But again, the people of genetics usually they request the Sanger for confirmation because it's more specific. So when you use the Sanger, when you use the whole exome sequencing, you would detect many potential mutations, even beyond the phenotype that you are looking for. But when you use the Sanger, usually it's exactly like when you do an ANA and it's positive. So you would ask for an anti-DNA to be sure that this is a specific lupus, for example. Even when we supplied our paper.
But my question, Professor Ahmed, my question for you is that the Sanger is a limiting factor for the analysis because it analyzes known mutations.
Single gene, yes, known mutation, single gene.
Yes,
that's why it's not.
It is not including. It is not including de novo mutations which might be encountered by the WES.
That's exactly right, but that's why it's not to be used as a primary screening. But what happened actually when we submitted our paper that we have done in Alexandria to Frontiers, they asked for Sanger to confirm the mutation that we found, and we've done it. They accepted after that. So the point is, usually when you find the mutation, what happened is that particular patient was very keen to be transplanted. And when I discussed with him everything, he said to me that the geneticists told him that if you want to confirm this result, go for Sanger. So he told me I would go for Sanger. I told him, you don't need, it's there, just we'll monitor. He said, no, I will do it. And he did the Sanger, and the Sanger showed the same exact mutation that was apparent in the WES. The time frame, and this is an important point, the transformation from a VUS to a pathogenic or likely pathogenic is not because of the technique, it's because of the time. That at the time of the first test, it was classified as such. If we just log into that, this is an important issue to be understood for colleagues. If we just looked with the same mutation in the WES after 6 months, we would have found that it turned to a likely pathogenic, even without doing any further tests.
My very clear question is that the Sanger should include the mutation you are testing for, which is not always the case. Sometimes the Sanger panel is missing that mutation.
Exactly.
So
it's very narrow
consider
limits,
that the Sanger panel is including that mutation you are searching for. Anyhow, it's a very difficult task, and we learned a lot from you, Professor Ahmed.
Thank you.
And I wonder if there is any question in the question and answer, or Professor Yasser, do you have any questions awaiting?
Okay,
there are some
Kamal,
in the chat.
Yes, you can proceed.
Yes, sir, please.
Dr. Rami Abu Bakr is asking about a recipient with primary FSGS about living-related donation, as we've mentioned, they can proceed except if they have this specific mutation of the bodocin, which is the arginine 229 GL1 or GLN. With donor with sickle cell, I don't think that sickle cell patients are allowed to donate. It's a contraindication for them to donate. Sickle cell trait, I don't know, to be honest, but I'm not satisfied that a donor with even a sickle cell trait would donate because these patients are at higher risk of losing their kidney from thrombotic episodes. As we all know, that sickle cell can cause loss of the kidney at any time. So it's better not to leave him with one kidney. Thank you, Professor. Question: can we proceed for transplant for female patient with coenzyme Q8B mutation safely? The donor is her father. Do we need to do target panel test for him or phenotypically free? This is a very good example of a potentially reversible disease if it is catched early. The CoQ8 or CoQ8B is a disease that presents with resistant nephrotic syndrome that usually have some form of rapid progression to CKD in some of the patients, and that can be prevented if early picked up by coenzyme 10. They can be transplanted. Yes, they can be transplanted. There is almost no evidence of recurrence in the literature. The father is the potential donor. The father should be tested. And in this situation, he should be tested either by whole exome sequencing, which with a renal panel, or even a target panel for nephrotic syndrome or for CoQ group, which would be a very limited panel. So the answer is he can be the donor after checking him with a WES or a target panel. If opting to proceed with transplant. Yes.
The issue here, Dr. Ahmed, is that even in autosomal recessive situations, which would manifest in the child and not manifesting in her parents, even the autosomal recessive situation might have a potential risk for manifesting in a subclinical way. So this should be taken cautiously.
Yes, of course. This is very important, yes. We even mentioned that in cases of Alport syndrome. In Alport syndrome, in female with an Alport who is an X-linked, in cases of X-linked Alport, the female should not manifest the disease. But literature have found that if a female with an X-linked Alport son, for example, it's better not to donate her kidney if she had any evidence of proteinuria, and if she is above 45 years of age and do not have proteinuria, she can donate, but she also have to be consented for a higher risk of progression. Although she's this is an X-linked disease and she's a female, and this is an X-linked recessive, so she should not be manifested. So carriers of the trait can be manifested in a way or another.
This mandates the proceeding with the diseased or unrelated or diseased better transplantation, and this should be one of our national protocols or programs to enhance the initiation of the cadaveric transplantation, which is not accepted anymore to have any.
Hopefully, Professor Gamal, to end this dilemma and start the bird donation and the cadaveric transplantation, inshallah.
Okay, that's very fine. Do we have any more?
One question.
Last question in the chat, Dr.
Yes,
Yasser?
there is one question here. If opting to proceed with transplantation, at which time it is the best to start complement inhibitor? I think he's asking about a typical HUS. The best time is to start the pre-transplant. You should start it shortly pre-transplant and then put the kidney and continue on with the ocrelizumab after that, inshallah. Last question is, a child with a corticosteroid-resistant nephrotic syndrome, should we genetically test for all gene mutation? Yes, there are almost 55 genes for this situation, but they are well gathered in one panel, which is the panel for steroid-resistant nephrotic syndrome, because you don't know whether they will be MYH1 to 9 or this would be nowadays. There have been link between collagenopathies even and nephrotic syndrome and IgA nephropathy, and things are intermingling. So if you go for Bodocin and NPHS and only these nephrin 1 and 2 and those, you might miss other types, like for example the cupin and the coenzyme QB and others. So the best thing is to do at least a target panel for steroid-resistant nephrotic syndrome.
I think this is very clear now, the importance of the genetic analysis, and you highlighted to which category of patients we would proceed with the genetic testing, and when it is mandatory to screen for the family as well, or only for the patient, and in such situations where we need specific treatments or therapeutic modalities, or choosing which type of donor for the patient. It has been very clear and very important issue, and thank you very much, Dr. Ahmed, for your very elegant presentation. It has been very fruitful, and you highlighted very important issues. Thank you very much.
Thank you, Professor Gamal. Thanks, everyone. Thanks for your patience as well. And inshallah, see you soon, maybe tomorrow morning, inshallah.
Inshallah.
Okay.